Hello friends, myself Dr. Mohammad Rafiullah. I'm an anesthesiologist and I'm going to teach you preoperative assessment and monitoring in anesthesia. So in pre-op assessment, what is the objective? Our objective is to ascertain the health of a patient who are to undergo the surgical intervention with the aim of controlling and reducing the risk of mortality and morbidity during anesthesia and surgery. So our objective is to ascertain the health. Basically we are called perioperative physician. Perioperative physician. Okay, so we have to ascertain the health of the patient who are to undergo surgery, okay, with the aim of controlling and reducing the risks associated with anesthesia and surgery. Okay, so for this objective, one system is there which is called ASA classification. It is American Society of Anesthesiologists classification. So ASA classification is there and it is in use for more than 60 years. Okay, and what does it do? It quantifies the risk associated with the surgery. It is classified into 6 categories, 1 to 6. Okay, it is very important. It is given on the site of American Society of Anesthesiologists that it was last amended on December 13 to 2020. Last amended on 13 December 2020. Okay, it has 6 categories. Okay, so in ASA grade 1, what does it include? ASA grade 1 includes normal healthy patient. That means the patient doesn't have any mental or physical illness. Okay, normal healthy patients. Okay, what does ASA 2 includes? ASA includes patient with mild systemic disease. Okay, what does mild systemic disease include? It includes current smoker, social alcoholic drinker, not an habitual alcoholic drinker. Okay, pregnancy is included in ASA 2, obesity in which BMI is 30 to 40 is included in ASA 2, controlled diabetes mellitus, not uncontrolled, controlled diabetes mellitus, controlled hypertension is included in ASA 2. So patient with mild systemic disease. So what does it include? Current smoker, it includes social alcoholic drinker, it includes pregnancy, it includes obesity with BMI 30 to 40, it includes controlled hypertension and controlled diabetes mellitus. Okay, so now ASA 3. So ASA 3 is the patient including ASA 3 are having severe systemic disease. What does severe systemic disease include? Poorly controlled hypertension, poorly controlled diabetes, COPD, morbid obesity. What is morbid obesity? The range is more than 40. It is in morbid obesity. Active hepatitis comes in ASA 3. Implanted pacemaker comes in ASA 3. History of MI, CVA or TIA means transient ischemic attack, or CAD or stent. If the history is more than 3 months, then it comes in ASA 3. Preeclampsia with severe features comes in ASA 3. So we will now write what does come in ASA 3 is poorly controlled diabetes mellitus, hypertension, COPD, okay, morbid obesity, where BMI is more than 40, okay, active hepatitis, history of CVA, TIA, MI or CAD and stent placement. If the history is more than 3 months, then it comes under ASA 3. Also, preeclampsia with severe features comes in ASA 3. Now, what does ASA 4 include? A patient with severe systemic disease that is constant threat to the life, it comes in ASA 4. So what does ASA 4 include? ASA 4 include recent TIA, recent CVA, recent MI or CAD or stent placement. If the duration is less than 3 months, then it comes in ASA 4. Sepsis comes in ASA 4. DIC, that means disseminated intravascular coagulation, comes in ASA 4. End stage renal disease not undergoing regular dialysis comes in ASA 4. Preeclampsia with severe features and it is complicated by HELP syndrome, it comes in ASA 4. So we'll now write what is ASA 4. A patient with severe systemic disease that is constant threat to life. So what does it include? Recent TIA, CVA, CAD, stent or MI if the duration is less than 3 months. Sepsis comes under ASA 4. Sepsis, DIC, end stage renal disease not undergoing regular dialysis comes in ASA 4. Preeclampsia with HELP syndrome comes in ASA 4. Okay. Now in ASA 5, what does it include? It includes a moribund patient who is not expected to survive without the operation. What does it include? It includes the moribund patient who is not expected to survive without the operation. Okay. So what does it include? It includes, it's very important, the question comes from here: ruptured abdominal or thoracic aneurysms. Massive trauma comes under ASA 5. Intracranial bleed with mass effect comes in ASA 5. Uterine rupture also comes in ASA 5. So we will now write ASA 5. The moribund patient who is not expected to survive without operation. So it includes ruptured thoracic abdominal aneurysm, massive trauma, intracranial bleed with mass effect, uterine rupture comes under ASA 4. So now what does ASA 6 include? ASA 6, it's very important. ASA 6, ASA 6 is a declared brain dead patient whose organs are to be preserved for donor purposes. So ASA 6 includes a declared brain dead patient whose organs are to be preserved for organ donation. Okay, so and one more thing, in the addition of E is done if the patient is taken under emergency. Suppose abdominal or ruptured thoracic aneurysm is there, it comes under ASA 5, but it has to be taken under emergency, then we will write ASA 5E. Okay, ASA 5E, ASA 2E, ASA 3E. Okay, likewise we will do the ASA grading. Now a very important topic which we are going to study is preoperative modification of pre-existing drugs. Pre-op modification of pre-existing drug therapy. Very important, questions always comes on this. So first is antiplatelets drug. Antiplatelet drugs. So aspirin is an antiplatelet drug. It is started in 2 doses. If the dose is 75 mg, then it is called low dose. If it is more than 75 mg, it is called high dose, or it is not low dose. Okay, for if 75 mg is being given to the patient, and if it will categorize in 2 categories: more than 75 mg, less than 75 mg. If 75 mg is being given to the patient, it should be continued till the day of the surgery. Okay, and if it is more than 75 mg, it should be stopped 3 to 5 days prior to surgery. Okay, should be continued till the day of surgery, and if it is more than 75, stopped 3 to 5 days before surgery. Next drug is clopidogrel. It is also an antiplatelet drug. So it should be stopped 7 days prior to surgery. Stopped 7 days prior to surgery. Okay. Now ticlodipine is also an antiplatelet drug. Ticlodipine should be stopped at least 14 days prior to surgery. It should be stopped 14 days prior to surgery. 14 days prior to surgery, it should be stopped. Second category is MAO inhibitors, monoamine oxidase inhibitors. Older MAO inhibitors causes severe sympathetic reactions with betadine, which is not used now. So okay, older MAO inhibitors should be stopped 3 weeks prior to surgery. Okay, newer MAO inhibitors like selegiline, it can be continued up to 1 day before surgery, but if question comes, you have to mark 3 weeks prior to surgery. So older MAO inhibitors 3 weeks prior to surgery. Newer, it should be newer like selegiline, should be continued up to 1 day before surgery. Okay, now next category is oral hypoglycemic agents or insulin. So in it is being given, then morning dose should be omitted always. FBA should be done on the day of the surgery. For major surgery, OHA is shifted to insulin. Okay, and it should be done, OHA shift to insulin is done 48 hours prior to surgery. Okay, now comes oral anticoagulants. The oral anticoagulants are warfarin. It should be stopped 4 days before surgery, and it should be switched to heparin. Okay, so warfarin is, if the patient is taking warfarin, it should be stopped 4 days prior to surgery, and it should be switched to heparin. Okay, for surgery, INR should be less than 1.5. Okay, and for emergency surgery you have to give vitamin K or FFP. FFP is fresh frozen plasma. Okay, for surgery INR should be less than 1.5. Okay, and for emergency surgery you can't wait, then in emergency surgery you should give vitamin K and fresh frozen plasma. Okay, what if low molecular weight heparin is being given? What if unfractionated heparin is being given? So if low molecular weight heparin is being given, it should be stopped 12 hours prior to surgery, and if unfractionated heparin is being given, it should be stopped 6 hours prior to surgery. Low molecular weight heparin and unfractionated heparin, it should be stopped, low molecular weight should be stopped 12 hours prior to surgery, it should be stopped 6 hours prior to surgery. Okay, now antihypertensive drugs. So all antihypertensive drugs should be continued till the day of the surgery, except ACE inhibitors and ARBs. ACE inhibitors and ARBs can cause refractory hypotension during spinal anesthesia. So we have to omit the morning dose. Somewhere it's written omit the morning dose, somewhere it's written don't omit them. But if ACE inhibitors are being given or angiotensin receptor blockers are being given, then there are the chances of refractory hypotension during the spinal and after the spinal anesthesia. Okay, now lithium. A lot of question comes, a lot of exams have lithium as direct question. Lithium should be stopped 2 days prior to surgery. Why? Because it is stopped 2 days prior to surgery. Why? Because it prolongs non-depolarizing muscle relaxants action during surgery. So if non-depolarizing muscle relaxant action is prolonged, then the chances are there that the patient will awaken lately after the surgery. So it should be omitted. What is steroid? So steroid is very important during surgery, and steroid the status of steroid is that it should be continued till the day of the surgery. Morning dose is to be given. Okay, what is the preoperative corticosteroid coverage? patient. So if the minor surgery is there, if the minor surgery is there, it is categorized in 3 categories: minor, moderate and major surgeries. If there is the minor surgery, patient takes 1.5 to 2 times her usual prednisolone dose on the morning of surgery. If moderate surgery is there, 2 times of the usual dose orally, and 25 mg hydrocortisone IV before surgery should be given, plus 75 mg during surgery and 50 mg IV after surgery. It is the standard guideline. What if major surgery is there? If major surgery is there, then 2 times of the oral dose in the morning patient is given, then 50 mg of hydrocortisone IV before surgery, 100 mg IV during surgery and 100 mg IV Q8 hourly, that is 8 hourly after surgery till 24 hours of the surgery. And it should be tapered over 48 hours. Dhire dhire we have to taper. So we will write minor surgery, moderate surgery and major surgery. So patient is given 1.5 to 2 times the usual oral dose in the morning. Moderate, 2 times oral dose plus 25 mg before surgery, IV hydrocortisone plus 75 mg during surgery plus 50 mg IV after surgery. If major surgery is there, then 2 times oral dose is taken by the patient plus 50 mg before surgery hydrocortisone IV plus 100 mg during surgery plus 100 mg Q8 early for 24 hours, and it should be taper over 48 hours. Okay, it is very important. Thank you, friends. Wait, we have left one thing. If the patient is a smoker, then it should be stopped 6 to 8 weeks before surgery. Smoking should be stopped 6 to 8 weeks before surgery. 6 to 8 weeks before surgery. What if herbal medicine is being taken by the patient? If herbal medicine is being taken by the patient, then you have to stop it for 6 to 8 weeks before surgery. One very important thing is OCPs, oral contraceptive pills. It should be stopped 4 weeks before surgery. Only progesterone pills can be continued till the day of surgery. And important thing is, drugs which can continue till the day of surgery are levodopa, antiepileptics, anti-anginals, thyroid drugs, statins. So which should be continued till the day of surgery is levodopa, anti-epileptics, anti-anginals, thyroid drugs and statins. Thanks, friends.